Welcome back to the Deep Dive. Today we're doing something a little different. This isn't just another exploration of a topic. I want you to imagine for a moment that the recording studio has just faded away. You're not in your car, you're not on your morning run, you are sitting in a very stiff chair, your palms are probably a little bit sweaty, and sitting right across from you is a senior faculty member. You're the candidate, the exam is the Gujarat University MD Anesthesiology Finals, and the topic on the table.
Well, it's one of the most classic, high-stakes, adrenaline-pumping scenarios in our entire field.
It really is the ultimate test, and that's exactly how we're going to treat this session. Think of this as a one-on-one intensive coaching session. And the topic, anesthetic management of foreign body aspiration and impaction. And it's a topic that examiners absolutely love.
Why is that? What makes it such a favorite?
Because it tests everything all at once. It's not just one skill. It tests your crisis management, your fundamental grasp of pediatric physiology, your hands-on airway skills, and maybe most importantly, your ability to keep a cool head when the room is descending into chaos. Exactly. It's the kind of Viva question that really separates the people who've read the book from the people who understand the principles. It separates the novices from the consultants. Now, before we jump into that pressure cooker, let's just lay out our sources. Where are we getting our intel from? We haven't just pulled this out of thin air. We've pulled together a pretty serious stack of the heavy hitters for this one.
We certainly have. We are synthesizing this entire deep dive from the gold standards. We have Miller's Anesthesia with us, which is, the Bible for all the physiological underpinnings.
A Bible, for sure.
Then there's Morgan and Mikhail for the clinical flow, the step-by-step. We've also consulted O's intensive care manual for the critical care aspects, which are, believe me, very relevant here.
And what about the exam-specific stuff, the things that are really tailored for this kind of high-pressure situation?
And that's the key. For the exam-specific nuances, we are looking directly at resources like Kaushik Jothanoff's Anesthesia Review and long and short cases in anesthesiology. These are built for this exact purpose.
That is a formidable stack of books. And it makes our mission for today really clear. We're going to construct the perfect verbal model answer.
Yeah.
So whether this comes up for you as a 20-mark theory question or as that rapid-fire Viva Voce scenario where the examiner is actively trying to trip you up, by the end of this hour, you will have the script.
That is precisely the goal. We want to move you from a place of, I think I know what to do, to a place of, I can explain the physiological rationale for every single move I make under pressure.
I love that.
Yeah.
Okay, so let's set the stage. Part A, the introduction. I'm sitting in the exam hall, I turn over the paper, and there it is. Discuss the anesthetic management of foreign body aspiration. How do we even begin? I can't just put them to sleep and pull it out.
No, definitely not. That's an immediate fail. You need to frame the problem professionally. You start with the definition and the scope. You'd say something like, foreign body aspiration is the inhalation of any object, animate or inanimate, into the respiratory tract. Simple. But then you immediately have to pivot to the who.
The demographics.
Exactly. And both Miller and Anesthesia Review are crystal clear on this. This is overwhelmingly a pediatric problem.
Right. We're talking about the little ones. Toddlers, mostly.
Specifically, the peak incidence is between 6 months and 3 years of age. This is that oral exploration phase. Everything they pick up goes straight into their mouth. And just as a minor point, a lot of clinical data suggests a slight male predominance. For whatever reason, boys in this age group tend to get into this kind of trouble a little more often than girls.
Okay, so we've established the who. Now for the why. Why is this considered such a critical anesthetic emergency? Why does the examiner's own pulse rate seem to go up just by asking about it?
It all comes down to the stakes. The potential for a total, irreversible loss of airway is real, and it is immediate. OB's intensive care manual talks about the concept of the café coronary, that's fatal food asphyxiation, which we see in adults. But in children, the margin for error is razor thin. It's almost non-existent.
Why is it so much more dangerous in a child?
Well, think about it. Their airways are small, they're conical, not cylindrical like in adults, and their basal oxygen consumption is massive compared to in adults on per kilogram basis.
So you have a very small tube and a very high demand for oxygen. That sounds like a terrible combination if you happen to block that tube.
It's the worst combination. And here's the single most important framing concept that you must nail for the exam. Write this down in your mind. The primary risk is converting a partial obstruction into a complete obstruction.
Okay, unpack that for me.
The child comes in, they're breathing, maybe they're stridorous, maybe they're wheezing, but they are moving air. The obstruction is partial. The moment you induce anesthesia, you risk relaxing the muscles that are splinting that airway open, or the object moves slightly, and suddenly you have a silent chest, no air movement. That is a nightmare scenario.
That phrase, converting a partial obstruction to a complete obstruction, that sounds like something I should probably underline in my mental notes.
Highlight it, underline it, tattoo it on your brain. That is the core tension of this entire case. Your every action is designed to prevent that from happening.
Okay, so we know the stakes are incredibly high. What are the patterns we need to be ready for? How does this question actually show up in the exam?
You'll typically see it in one of three ways. First, there's the big theory question. Discuss the anesthetic management of a 2-year-old with a history of peanut aspiration. That's your 20 marker.
The long answer.
Right? Second, you might get it as a short note. Something more specific, like jet ventilation for bronchoscopy or management of laryngospasm. And third, and this is the one that gets people, is the Viva trap, the direct scenario-based question. You are inducing a child for FB removal and they desaturate. What do you do?
And we are going to cover all three of those angles.
Excellent.
Let's move to part B, the general principles. Before we get into the specifics of location like the nose or the bronchus, what are the overarching rules of engagement here, the things that apply no matter what?
There is one golden rule, and it overrides everything else. Everything. The airway is the first, second, and third priority.
So everything else is secondary.
Everything. Fasting status, pre-medication, systemic history. All of it is secondary to establishing and maintaining a secure airway.
Okay, and does the location of the object itself change your fundamental strategy?
Drastically. You have to differentiate between a supraglottic, a glottic, and a subglottic or bronchial foreign body. A supraglottic object, something sitting above the vocal cords, is an immediate threat to life because it can just flip down and occlude the inlet entirely. A glottic object, one stuck between the cords, is a huge risk for spasm.
And a bronchial one.
A bronchial object, while still very dangerous, usually allows for ventilation of the contralateral lung, so you have a bit more time. The urgency and the technique are completely different for each site.
That makes perfect sense. Now, let's circle back to that partial versus complete dynamic. You mentioned it's the core tension. Anesthesia review gives a very strong warning about agitation in these children. Why is a crying child such a dangerous child in this specific context?
Think about the physics of crying. It's not just noise. It involves deep, forceful, turbulent inspirations. Now, if you have a mobile foreign body, say a peanut just sitting in the trachea or loose in a bronchus, a massive inspiratory effort can do one of two things. It can suck that object deeper, wedging it firmly into a smaller airway.
Making it harder to get out?
Much harder. Or worse, it can suck it up from the bronchus and lodge it against the glottis from below, and then you have a complete obstruction.
So, keeping the child calm isn't just about being nice or getting IV access. It's actually a survival strategy.
It is a physiological necessity. This is where the concept of a steal induction comes from. We try to avoid anything that causes distress. We avoid painful IV starts while they're awake if we can. We want a smooth, calm, gentle drift into sleep, specifically to avoid that dynamic, high-flow airflow that can move the object into a worse position.
Okay, now let's unpack what feels like the biggest debate in this whole field, ventilation strategy. Spontaneous versus controlled ventilation. I feel like this is where a lot of students get really tripped up.
This is the absolute crux of the anesthetic discussion. It's a classic Viva question. The overwhelming consensus from both Miller and Anesthesia Review is that spontaneous ventilation is preferred, at least initially.
Why is that? I mean, intuitively, it feels like it would be easier to just paralyze them, intubate, and take complete control of the situation.
It would be easier for you in that one moment, but it could be potentially fatal for the child. See, when a patient breathes spontaneously, the diaphragm contracts, creating negative intrathoracic pressure. This actively pulls the airways open. It's like a tenting effect. The airway diameter is maintained or even increased.
Okay, so their own breathing helps keep the airway open.
Exactly. Now, if you paralyze them and use positive pressure ventilation, or PPV, you are actively blowing air in. This can push the foreign body further down the airway, like a piston.
Ah, the piston effect. I see. So positive pressure pushes the object deeper, whereas their own negative pressure, their spontaneous breathing, helps keep the airway patent around it.
You've got it. That's the core mechanical concept. Plus, if you use muscle relaxants, you lose all the muscle tone of the pharynx and the larynx. The whole structure can become floppy and collapse around the object, causing that complete obstruction we fear. So the mantra is, Maintain spontaneous ventilation until the airway is definitively secured or the surgeon has eyes on the target.
And we can't forget, this is never a solo mission.
Never. It's the classic shared airway scenario. You and the ENT surgeon are, quite literally, fighting for the same piece of real estate. You cannot work in a silo. Miller has a whole section on this. Communication is not just important, it's vital. You need to agree out loud on who has the airway at any given moment. You need to clearly state when you are ventilating and when they are working.
It's a constant verbal dance.
A very careful one, yes.
Okay, let's move on to the preoperative assessment. This is part B, section 3. We're in the pre-op holding area with the child and their parents. What are we looking for in the history? What are the key questions?
You're hunting for the triad of history, but a really high-yield way to present this in an exam is to use the phases described in anesthesia review. Phase 1 is the immediate phase. This is the event itself. You ask the parents, was there a sudden episode of choking, gagging, violent coughing, or even cyanosis?
But the problem is, parents don't always bring the kid in right at that moment, do they?
No, they don't. And that leads directly to phase 2, which is the asymptomatic phase. This is the big trap for clinicians. The child's initial violent reflex is fatigue, or the object lodges itself in a bronchus and just stays put, the coughing stops, the parents think, oh, phew, he must have swallowed it. He's fine now. But he's not fine.
And what happens next?
Days or even weeks later, phase 3 begins. The renewed symptomatic phase. Infection starts to set in around the object. You get inflammation, pneumonia, or granulation tissue starts to form. This is when you might see a child who's been treated for asthma for a month, but it's just not getting any better.
That's a classic exam vignette, isn't it? A child with refractory asthma and maybe a persistent right-sided wheeze.
That is a foreign body until proven otherwise, 100%. In the physical exam, your stethoscope is your best friend. Auscultation is key. You are listening intently for unilateral decreased air entry. That is the absolute classic sign of a bronchial obstruction.
Any other key signs?
Yes, but this intensive care makes a great point here. Listen to the child's voice. If you hear any voice changes, hoarseness, or especially aphonia, the inability to make sound, you should be extremely worried about laryngeal involvement.
That makes sense. The voice box is affected. What about imaging? We always get a chest x-ray, right?
We do, but you have to know how to interpret it, and more importantly, its limitations. Anesthesia review reminds us that things like coins, pins, or button batteries are radio-opaque. You'll see them plain as day. But what are the most commonly aspirated objects in children?
Peanuts, seeds, bits of carrot.
Organic matter, and plastic toys, all of which are radiolucent. You will not see the object itself on the x-ray.
So if the x-ray comes back reported as normal, we can't just send them home.
Absolutely not. That's another huge trap. A normal x-ray does not rule out a foreign body. You have to look for the secondary signs. The most important one is air trapping. Because of that ball valve effect, which we'll get into more detail on later, air gets in, but it can't get out. So on an expiratory film, the affected lung looks hyperinflated. It looks darker and bigger than the healthy lung.
Or the opposite could happen, right?
Yes. If the obstruction is complete, you won't see hyperinflation. You'll see the opposite. Atelectasis, which is lung collapse. The lung will look white and shrunken. You might also see a mediastinal shift.
Okay. And finally, for this pre-op assessment, fasting. These kids, by definition, have a full stomach, right? They might have just eaten a peanut.
Correct. You must always consider them to have a full stomach. But, and this is a critical nuance for the exam, airway security trumps aspiration risk. Long and short cases is very clear on this. We do not perform a standard rapid sequence induction or RSI.
Wait, why not? RSI is the standard for a full stomach. It's designed to protect against aspiration.
It is. But what does RSI require? A muscle relaxant. And as we've just established, giving a muscle relaxant before the airway is secured can kill the patient in the specific scenario. It can collapse the airway or dislodge the object completely. So we consciously accept the small risk of aspiration to avoid the very high and immediate risk of total airway loss. We proceed with a slow, careful inhalational induction, maintaining spontaneous breathing.
That's a fantastic point. Okay, let's start moving down the airway anatomically. Part C, foreign body in the nose and ear. Now, these might seem less dramatic than a peanut in the lung, but they are very high yield for short notes. Let's start with the nose.
Right. Foreign bodies in the nose. We're talking about beads, little bits of sponge, paper, buttons, and organic matter. And organic matter is particularly tricky.
Why is that?
Because it absorbs moisture from the nasal mucosa, it gets wet, and it swells. So a bean that went in easily can become very difficult to remove a few hours later.
And what about batteries? I've heard those are a special case.
Batteries are a true chemical emergency. Miller highlights this very well. A button battery lodged in the nose can cause liquefaction necrosis and septal perforation in a matter of hours. That's from the leakage of alkali and the local electrical current. It needs to come out now.
Okay, so what's the big anesthetic risk here? I mean, it's just the nose. It's not the airway.
But it can become an airway problem very, very quickly. The number one risk is posterior displacement. If the child gasps in fear, or if the surgeon is a bit clumsy with their forceps and pushes, that bead goes from the nose, through the nasopharynx, and drops right onto the larynx. And now you have a dire airway emergency that you didn't have a second ago.
Wow, that escalated quickly. How do we prevent that from happening?
The throat pack. It is absolutely essential. Before they start, you must pack the oropharynx to create a barrier, protecting the lower airway. Long and short cases also makes a good point about topicalization. Using vasoconstrictors like xylometazoline drops or adrenaline-soaked pledgets can help shrink the mucosa, improve the surgeon's view, and reduce bleeding.
Okay, moving next door to the ear. Why would a foreign body in the ear become an anesthetic issue? Can't the surgeon just pick it out in the clinic?
Often, yes, for a cooperative child. But for a young, uncooperative child or a very deeply impacted object, you need them to be perfectly still. The exam trap here, the thing they want to hear you mention, is the vagus nerve reflex.
The vagus nerve. In the ear.
That's right, Arnold's nerve. It's the auricular branch of the vagus nerve, and it innervates part of the external auditory canal. So stimulation of the ear canal during removal can, in rare cases, cause coughing, significant bradycardia, or even a systole. Anesthesia review specifically mentions this reflex.
Wow, so poking around in the ear can actually stop the heart.
In theory, yes. It's rare, but it's a known phenomenon. But the much more practical and common consideration is simply immobility. The surgeon is working with microscopic precision right next to the tympanic membrane, the ossicles, and the facial nerve. If that child jerks their head at the wrong moment, you can cause permanent deafness or facial paralysis.
So general anesthesia isn't just for comfort, it's for safety.
It's much safer than trying to do it under deep sedation, where you can't guarantee that absolute immobility. For these cases, GA is the way to go.
Right. Now let's get to the really critical stuff, the heart of the matter. Part D, foreign body in the larynx. This section is marked in our notes as absolutely essential.
And for good reason. This is the danger zone. A foreign body lodged at the level of the larynx is a life-threatening, can't-wait emergency. If it's a flat object like a coin and it turns sideways, it can block the glottic opening completely.
So what are the clinical features? How do we spot this immediately?
The presentation is usually dramatic and sudden. Sudden onset stridor is the hallmark sign. But the one red flag, the one that should make your own blood run cold, is aphonia.
Loss of voice.
Exactly. If the child cannot cry, can't make a sound, it means the vocal cords are involved or completely occluded. You'll also see severe respiratory distress, deep sternal and intercostal retractions, and advancing cyanosis. It's a terrifying picture.
Okay, so we're faced with a blue, silent, air-hungry child.
Yeah.
What is our management plan? This sounds like an exam favorite.
It's a huge exam favorite. The approach must be calm and systematic. You proceed immediately to the operating theater. The approach is a gentle inhalational induction, usually with sevoflurane in 100% oxygen, and you must maintain spontaneous respiration.
Okay, let me stop you there. Do we use muscle relaxants in this scenario?
Absolutely, unequivocally contraindicated. I cannot stress this enough. That is the million-dollar answer. If you give a muscle relaxant, you relax the laryngeal muscles, and the object might settle into the glottis and seal it shut completely. You keep them breathing no matter what.
Okay, so walk me through the technique. The child is on the table.
You start with sevoflurane in 100% oxygen. No nitrous oxide. We'll explain why later, but just remember that. You gradually deepen the level of anesthesia. Once they're deep and unresponsive, you can establish IV access if you didn't already have it. Then, a key step mentioned in Miller is to topically spray the vocal cords with lidocaine.
Why do we spray the cords?
To prevent reflex laryngospasm, you are about to introduce a metal laryngoscope and forceps into a highly irritated airway. The last thing you need is for the cords to slam shut around the object. You spray the area, wait a moment for it to take effect, and then the surgeon performs direct laryngoscopy and attempts to remove it with McGill forceps.
And what's our plan B? What's the oh-no moment procedure? Let's say total obstruction occurs during induction.
Right. If that happens and you cannot ventilate at all, you have two life-saving options. Option 1, push the object. Don't try to pull it out against a tight seal. Use your endotracheal tube or the tip of the laryngoscope to deliberately push the foreign body down into one of the main bronchi.
You're intentionally making it a one-lung problem instead of a no-lung problem.
Exactly. A right mainstem bronchus obstruction is survivable. You can ventilate the left lung. A complete tracheal obstruction is not survivable. Option 2 is an emergency surgical airway. The tracheostomy or cricothyrotomy kit must be open and ready on the instrument trolley before you even start the induction.
That is incredibly intense. Let's move just a little further down the airway to the most common site of all. Part E, foreign body, in the trachea and bronchus. Why is the right bronchus the most common site for things to land?
It's a simple question of anatomy, and examiners love to ask this. As both Miller and anesthesia review confirm, the right main bronchus is wider, it's shorter, and it's more vertical. It's in a more direct line with the trachea than the left. So gravity and airflow just naturally guide objects down that path.
Okay, let's really dig into the pathophysiology here. The ball valve effect. This comes up in textbooks and exams constantly. Can you explain exactly how that works?
I can, and you should be able to explain it just as clearly in your exam. Imagine the foreign body, let's say it's a peanut, is partially blocking a bronchus, but not sealing it completely. Now, during inspiration, the airways naturally dilate. This is due to the negative intrathoracic pressure pulling them open. So air is able to squeeze past the peanut and get into that segment of the lung.
Okay, so air gets in, no problem.
Right. But during expiration, which is a passive process, the airways naturally narrow. Now, the space around the object closes up. The air that went in is now trapped. It can't get out.
So at every single breath, you're essentially pumping more air into that segment, but little to none is coming out.
Precisely. This leads to a phenomenon called obstructive emphysema or hyperinflation of that lung segment or lobe. And that is why on a chest x-ray, the bad side, the side with the foreign body, can paradoxically look bigger and darker because it's full of trapped air. This can even cause the mediastinum to be pushed over to the good side.
That is a brilliant, crystal clear explanation. Thank you. So let's talk about the anesthetic technique for bronchoscopy. This is another absolutely essential section. What's the gold standard procedure for removal?
The gold standard is rigid bronchoscopy.
Not a flexible scope.
No, absolutely not for removal. Flexible bronchoscopes are fantastic diagnostic tools for looking, but they're terrible for working. Their suction channels are tiny, and you can't pass large enough instruments through them to grab something like a peanut. The rigid bronchoscope, on the other hand, is a hollow metal tube. It allows the surgeon to ventilate the patient through the scope. It has a large channel for effective suction, and they can use heavy, robust forceps to grab the object securely. It is the definitive tool of choice.
Okay, so we're doing a rigid bronchoscopy. What are our primary anesthetic goals here? It sounds like we're juggling a few things at once.
You are. You have 3 often competing goals. Goal number 1 is oxygenation. You have to keep the patient pink. Goal number 2 is immobility. The surgeon needs a completely still target. Coughing or bucking during a rigid bronchoscopy can cause a tracheal tear, which is a disaster. And goal number 3 is attenuating the profound stress response of having a metal tube in the airway.
And what are our ventilation options for this? We touched on spontaneous versus controlled earlier. What about something more advanced, like jet ventilation?
Jet ventilation is a very elegant, but also higher risk solution. This is discussed in detail in Morgan and Mikhail and Miller. Essentially, you attach a high-pressure oxygen source to a special sidearm on the rigid bronchoscope. You then deliver short, powerful bursts or jets of oxygen into the airway.
How does that ventilate the patient if the whole system is open to the air at the top?
It works based on the Venturi principle. The high-velocity jet of oxygen shoots down the center of the scope and entrains a large volume of ambient air along with it, pushing that mixture of air and oxygen down into the lungs. It's surprisingly effective for oxygenation.
It sounds effective. What's the catch? There has to be a catch.
The catch is risk, significant risk. The main one is barotrauma. If the airway becomes partially obstructed downstream, you can very easily blow a pneumothorax because you're using such high pressures. And there's also a risk of blowing debris or even the foreign body itself further down into the distal airways, making it impossible to retrieve. It requires a lot of skill and experience.
What about TIVA? Total intravenous anesthesia. Is that an option here?
TIVA has become very, very popular for these cases. A combination of Propofol and Remifentanil is a fantastic technique. Remifentanil is the star of the show because it's a potent, ultra-short-acting opioid. It profoundly suppresses the cough reflex, giving you that absolute immobility the surgeon needs, but it wears off almost instantly when you turn off the infusion. It gives you the stillness of paralysis without the commitment of a long-acting relaxant.
So intraoperatively, we're doing the bronchoscopy.
Uh-huh.
We're monitoring pulse oximetry as our #1 guide. Maybe a precordial stethoscope to listen to breath sounds. Why did you say no nitrous oxide earlier?
Right. Anesthesia review is very clear on this, and it's another good exam point. Nitrous oxide has a physical property where it diffuses into air-filled spaces much faster than nitrogen can diffuse out. So if you have air trapping behind a peanut because of that ball valve effect, nitrous will rapidly diffuse into that pocket of trapped air and cause it to expand, like blowing up a balloon.
Making the emphysema much, much worse.
Exactly. You could make it so bad that you rupture the lung or cause a tension pneumothorax. It's an absolute contraindication. Just use oxygen and air.
Okay, let's play out the critical scenario. The surgeon is down there looking for the peanut, and the sats start to drop. 90%, 85, 80. What do we do?
You have to be the captain of the ship. You don't ask, you tell. You say, calmly but firmly, stop.
Yeah.
The surgeon must immediately withdraw the bronchoscope back into the trachea or remove it entirely. You then take over, ventilate the patient with 100% oxygen via a face mask or through the scope itself until their saturation recovers completely. Only then do you allow the surgeon to try again.
This theme of surgeon communication just keeps coming up.
It is the most critical non-technical skill in this entire procedure. You need to use clear, closed-loop communication. I need to ventilate now. Okay, you have 30 seconds to take a look. You are constantly trading seconds of surgical time for minutes of physiological stability.
Okay, that makes sense. Let's move to Part F, complications. We've mentioned some of the big ones along the way, but let's formalize them for an exam answer. Intraoperative laryngospasm.
Miller identifies this as a top-tier risk, especially during periods of light anesthesia or on emergence during extubation. The airway is already irritated from the foreign body. There might be some blood. You've had a metal tube scraping around. The vocal cords are incredibly twitchy.
And how do we manage it when it happens?
The standard algorithm: first, apply continuous positive airway pressure, CPAP, with 100% oxygen. At the same time, perform a firm jaw thrust. Often that's enough to break it. If that fails, the next step is to deepen the anesthesia, usually with a small bolus of Propofol. And if that still fails and you cannot ventilate, you give succinylcholine.
But wait a minute, you've been telling me for the last half hour, no muscle relaxants.
And that's the nuance they're testing in the Viva. The rule is no relaxants before the airway is secured or the object is removed. But if you are in a can't ventilate laryngospasm crisis after the object is out, or during a failed attempt where you simply must break the spasm to oxygenate the patient, you use it. It becomes a rescue drug.
Got it. That's a crucial distinction. What about the common postoperative complications? The peanut is out, everyone is relieved. Are we out of the woods?
Not at all. Subglottic edema is the big one to watch for. It's also known as post-intubation croup. O's intensive care warns about this specifically. The rigid scope, even with gentle use, traumatizes the narrow subglottic region in a small child's airway. The swelling happens over the next few hours.
And the treatment for that?
First, cool humidified oxygen. Then, nebulized adrenaline or racemic epinephrine. This causes local vasoconstriction and helps to shrink the swollen tissues. And finally, steroids. Dexamethasone is almost standard practice now, given either during the procedure or at the end, as a prophylactic measure against this.
And pneumothorax.
You must always have a high index of suspicion and check for it, especially if jet ventilation was used or if the surgeon described the removal as a struggle. Before you leave the OR, you must listen carefully to both sides of the chest to ensure equal air entry.
This is all fantastic. Okay, Part G, comparison and exam integration. This is where we tie it all together to structure that perfect 20-mark answer. Let's create a mental table for the listener to visualize.
Right. This is a great way to study. Visualize a table with 4 columns for the 4 main locations: supraglottic, glottic, tracheal, and bronchial. For supraglottic, the keywords are immediate distress, drooling, dysphagia. The management is often direct laryngoscopy and removal with McGill forceps. For glottic, the keywords are stridor and aphonia. This is the highest mortality. The management principle is NO relaxants, and be prepared to push it distally if you have to.
What about the trachea and bronchus?
For tracheal, a classic sign is an audible slap or a palpable thud. The management is rigid bronchoscopy. And for bronchial, the classic triad is unilateral wheeze, cough, and decreased air entry. The pathophysiology is the ball valve effect and air trapping. And the management, again, is rigid bronchoscopy.
That audible slap, that's a great clinical sign. Is that the object literally bouncing up and down in the trachea with each breath?
That's exactly what it is. On expiration, the airflow pushes it up and it hits the underside of the vocal cords. You can sometimes hear it with a stethoscope on the neck.
Incredible. Okay, let's talk about the Viva traps. Section 16. The examiner is staring at you across the table. They lean forward and ask, "Doctor, why not just paralyze the child to make the bronchoscopy easier for the surgeon?"
You look them right in the eye and you say it with confidence, because the loss of airway muscle tone that comes with paralysis can collapse the airway around the object and may turn a partial stable obstruction into a complete life-threatening one. Furthermore, paralysis eliminates the negative intrathoracic pressure of spontaneous breathing that helps to keep the airway patent.
Perfect. Trap number 2. The chest x-ray is reported as normal. Can we discharge the child and have them follow up in clinic?
The answer is an emphatic no. You say no because the most commonly aspirated objects, such as peanuts, are radiolucent and will not be visible. A normal X-ray does not rule out a foreign body, and we must proceed based on the clinical history and suspicion.
And what about this concept of the dead space issue?
This is a more subtle physiological question they might ask. The rigid bronchoscope itself occupies a significant amount of space in the child's small trachea. It increases the resistance to breathing and increases mechanical dead space. In a small child, a 3.5 millimeter bronchoscope might take up half the cross-sectional area of their trachea. This makes spontaneous ventilation much harder work for the child, which is why we often need to assist their ventilation, even if we're trying to maintain a spontaneous technique.
Finally, diagrams. If I'm in the theory paper and I have a few minutes left, what should I draw to get extra marks?
2 diagrams will get you maximum points. First, draw the ball valve effect. It's simple. Draw 2 pictures of a bronchus with a peanut in it. Picture 1 is labeled inspiration. Show the airway dilated, and draw an arrow showing air easily going past the peanut into the lung. Picture 2 is labeled expiration. Show the airway narrowed with the peanut blocking the exit. Show the air trapped behind it. Label that air-trapping obstructive emphysema.
That's brilliant. That's worth 1,000 words. What's the second diagram?
The second is a simple diagram of the bronchoscope setup. Just draw the rigid scope and make sure to clearly label the side port for ventilation. It shows the examiner you understand the practicalities of the equipment you'd be using.
We have covered a massive amount of ground. This has been a masterclass. Let's summarize it all for the final exam conclusion, Part 18.
Okay, the high-yield bullet point recap for your conclusion paragraph. 1. The airway is shared. Emphasize teamwork and communication with the surgeon. 2. Spontaneous ventilation is safer initially. It preserves airway tone and prevents distal migration. 3. Rigid bronchoscopy is the tool of choice for removal from the lower airway. And 4. Anticipate complications, specifically post-operative subglottic edema, laryngospasm, and pneumothorax.
Fantastic. And to leave our listener with one final provocative thought, something to mull over.
Think about the post-anesthesia care unit, the PCU. We focus so intensely on the drama in the operating room, on getting the object out. But many of the resources, like OIS intensive care, suggest that the danger isn't over when the peanut is in the bucket. Most of the deadly complications, the severe subglottic edema, the reflex laryngospasm, the unrecognized pneumothorax, they often manifest after the scope comes out in the recovery room. The PTU is your final critical safety net. Do not drop your guard there.
What a crucial point. Vigilance doesn't end when the procedure does.
My final piece of advice for you in the exam is this. Be safe, be slow, and always prioritize oxygenation over the speed of removal. Your primary job is to just keep them breathing.
That is a perfect mantra to end on. Just keep them breathing.
Yeah.
Thank you so much for this incredible deep dive. To our listeners sitting in that metaphorical exam chair, good luck on the Gujarat University exams. You have the knowledge. Now go and apply it. Review that ball valve diagram and the pharmacokinetics of sevoflurane for the Viva.
You've got this. Good luck.
We'll see you in the next deep dive.